Mr. Sharif, he has Master in Health Administration. Forgive me, the CV is very rich. Just I will take some of it. He also managed different healthcare provider in US, integrated care, awarded many prizes, participate effectively on the triple of the revenue, and this is also one of the triple M we will see later. Mr. Sharif, we have a lot of questions. What is accountable care organization? And what is the relationship between accountable care organization and the patient safety? And again, what is the contribution of accountable care organization to the population health? So the floor is yours. Thanks again and welcome to our group. Can you unmute, please, Mr. Sharif? Yeah.
Assalamu alaikum. Bismillah ar-Rahman ar-Rahim. Thank you, Dr. Hatem, for the wonderful introduction. As Dr. Hatem mentioned, I have spent most of my career, or all of my career, up to about a year ago, managing different hospitals or health systems within the United States. So I know Dr. Hatem asked me to speak about ACOs today and how ACOs relate to patient safety within the organization. I'll preface this presentation to say there are subject matter experts on ACOs and there are subject matter experts on patient safety. My entire career has been in hospital leadership, mainly CEOs of various health systems. So while I've had oversight and accountability for both of these areas, I'm sure there are people on this call that are more informed maybe on each individual one and maybe collectively. I'll also say, going into this presentation, obviously there are many definitions of what an ACO is, particularly when you start talking about ACOs in different countries or different continents. As obviously as my career has been spent in the United States, this presentation will be approached from the United States definition, which also has several definitions of what an ACO is. So without ado, I'll start the presentation, and inshallah, let me see. Right. So what are ACOs? And again, there are a lot of different definitions, and there's very technical definitions, but essentially, and I know you've had some previous presentations along ACO, so I won't spend a lot of time on this, but essentially it's taking individualized providers. So whether that's a hospital, a physician, a group of physicians, a long-term care facility, and including the managed care organizations. And as Dr. Hatem said in his introduction, really building an infrastructure that integrates those deliveries and moves it away from being a silo into a fully integrated health system. Not necessarily a fully integrated healthcare system, because obviously there's the prevention and the population management, which plays a key role. And therefore, providers have to move away from just simply treating the acute syndrome to moving into more of that prevention and thinking about the overall wellness of the community that it serves. Obviously, healthcare in the United States is focused on improving patient outcomes. But for those of you who've spent any amount of time in the U.S., you also know that it's a business, whether it's a for-profit organization or not-for-profit organization. Healthcare plays a critical role in our business plays a critical factor in a lot of the decisions that are made. So when you look, I say this because when you look at particularly the environments that I've worked in, so I've spent my entire career working for the two largest for-profit healthcare chains in the United States. And their decision to become or form in specific markets ACOs took a lot of time and took a lot of analysis. And strategically, neither one made the decision to be first to market, because obviously there's embedded risks when it comes to that. Now, that didn't mean that they weren't focused on becoming a high reliable organization and making sure that we follow the proper process to improve patient safety, whether it was safety huddles or handoffs or making sure that patients get to their primary care office within a certain amount of time. But the reason for the delay in necessarily forming an ACO or in other factions clinically integrated networks is because it's a financially risky decision within the United States, because you go from a fee for service where, yes, you focus on patient safety, but the reality is if you have a readmission or if you have a hospital acquired conditions, in most circumstances, you'll continue to get paid on a fee for service. Versus moving into a capitated model is when you get into obviously much more risks. And so you need to make sure that your quality and your safety outcomes are strong before you go into an ACO setting to ensure that you're able to execute on that capitated model. So obviously, improving patient safety, improving quality is a focus and a critical factor for all health systems within the United States. But the byproduct of that is to be able to achieve the efficiencies that are required to be profitable within an ACO model. And I'll come back to this more towards the end of the session. ACOs are also critical in beginning through the integration is through integrating data. Obviously, electronic medical records have been around for a while. In most places within the United States, there are still a couple of doctors that are holding out, but I'd say 99% of the providers in the United States have electronic medical record. So this doesn't mean that necessarily everyone's on a unified medical record, but what it does mean is that there's some interface, whether it's a health exchange or some IT overlay, that begins to allow independent providers, whether it's a hospital, a physician, a long-term care facility, to begin sharing data with one another. And the reason that's critically important is obviously, one, from a patient management, but two, to be able to identify trends, quality trends, safety trends that need to be addressed to be able to deliver the right care in the right setting. And then finally, ACOs is not a cost containment in terms of let's manage, expenses, manage FTEs. It really is looking at how do you improve patient outcomes, which in turn is an impact on decreased costs. So this is by, obviously, as we all know, reducing readmission rates, reducing hospital-acquired conditions, reducing duplication of services, the same patient getting multiple MRIs because different factions are not talking to one another. So the premise of the ACO is really to build that integrated network. There are various versions of ACOs. There's various versions of value-based organizations, whether it's an ACO, a clinically integrated network, a management service organization. But even within ACOs, there's various versions where you see in some areas very large primary care groups becoming their own ACO. Versus multi-specialty groups also forming ACOs, versus health networks which employ doctors and have relationship with independent doctors. And you're also beginning to see long-term post-acute care facilities forming their own ACOs. So again, the providers can be very different. Different ACOs can collaborate with one another, but at the end of the day, the root of it all is to to enhance integration between different care providers, to improve the overall quality of care, and to begin having enough data to implement preventative measures to help improve the overall health of the community. We touched about this, but the reason for the ACO is the fragmentation and discontinuities in healthcare services are key factors that contribute to poor health outcomes, decreased quality and safety, and escalating healthcare costs. So a perfect example of this is at one of my facilities, we had a patient that appeared in our emergency room 40 times in 1 year and was admitted onto our mental health ward 4 times in the same year. Previous to that year, we had never seen the patient in the hospital except one time before, and that was from their OBGYN. So when we started digging into the specific indicators of the patient, it was clear to us that the issue that surfaced was post delivery. This specific patient began to suffer from mental health issues, whether postpartum depression or something unrelated to that. But that is when we began to see the high utilization of healthcare, the bouncing from one facility to another. But I can tell you the only reason that we were able to pick up the trend on this specific patient is because we formed a work group between the hospital, the physicians, not-for-profit communities that were focused on providing grants to improve the overall wellness of the community, and various nonprofit behavioral health providers. So it was, and that wasn't at that point, it wasn't even an ACO. It just was the beginning of conversations. And so you can see just by having multiple key stakeholders sitting at the table, you can begin to identify trends and begin to introduce interventions to help improve the wellness of a specific person. This same work group looked at emergency room visits and looked at the zip code analysis within the US, within the community, within the market share of the hospital. And we identified specifically one housing complex that was low income housing that had high utilization of the emergency room, high readmission rates. And from there, we were able to sit down with partners, identify working with the government agencies, again, working with not-for-profits to identify where specifically we were seeing this high utilization, and then begin introducing care coordinators and health coaches within that specific apartment or low-income complex to begin working directly with the community to help improve their outcome rather than waiting for the acute setting. So I say all this because fundamentally an ACO is intended to bring multiple people together, multiple stakeholders together to work on improving the overall wellness of our community. As it relates to patient safety specifically, here's one slide showing you just how an accountable care organization can work with various stakeholders with the accountable ACO being at the center. The ACO does not necessarily have to be the primary care doctor, all the specialty doctors, or the ambulatory centers, or the hospitals. An ACO in the United States can be an independent body that pulls all these entities together through various legal contracts, through various collaboration agreements. So many of these ACOs in the United States, they remain independent, the individual stakeholders, but they agree to certain terms and conditions to collaborate with one another. That's overall governed by a managed care contracts with clear quality, safety, and financial outcomes. So ACOs will need to form seamless provider networks that are collectively responsible for providing safe, high quality care across the continuum of healthcare services, from primary care to long-term care. I'll pause here and say, you know, ACOs and patient safety are directly but indirectly also related. So the reason I say this is because there are still many hospitals or many organizations in the United States that are not part of ACOs. However, they are high reliability organizations that have really worked at improving their patient safety, decreasing serious safety events, and really identifying how to prevent those events from happening. So I've been part of organizations, and I know there are many other organizations out there that have implemented the strategies around high reliability, and have gone more than 1 year without a serious safety event. This is due to the transparency and the comfortness of the staff to report potential issues so that we begin working through the issues. So ACOs help in terms of creating the communication between the providers, but patient safety is something that should be done regardless if someone is part of an ACO or not. But by doing the right things around patient safety, it will obviously have an impact of the ACO achieving their goal. So one really cannot live without the other. An ACO cannot live without implementing proper patient safety initiatives. And patient safety initiatives will help drive ACOs to be successful of the desired outcome. When you talk about an ACO and all the different components that are required, you can see that there's a lot of infrastructure, whether it's an IT infrastructure or whether it's a manpower infrastructure from primary care engagement, specialty care engagement, introducing new jobs like care coordinators and health coaches, as well as the analysis of all the data that's gathered. So for example, many organizations or some of the robust ACOs in the United States, their IT department or their network analytics department has anywhere between 200 and 300 people working in there, because they are they have millions of data points that are able to really identify trends, look for opportunities, and begin introducing interventions that drive into network governance, and then obviously the value that comes from all of those initiatives. I'll say ACOs are also something that is not just a healthcare provider initiative within the United States. It's also driven by the private sector from an employer standpoint. So, for example, Walmart, which is the largest or was competes with Amazon as one of the largest employers in the United States, has one of the most, Walmart is a retail chain that sells anything from grocery stores to clothes to everything, like a Hyper Panda or a Hyper Lulu. However, they have, since they have so many employees, they've created their own data warehouse of health claims that from all of their employees. And they actually probably have better information than most healthcare systems or most managed care companies have about their patients. And so what Walmart's been able to do, and part of the reason I know this is I was the CEO of a health system that had an ACO in the same town that Walmart's corporate office was. So routinely, I would need to go meet with their corporate office because they had 60,000 employees in this one town and they wanted to manage their healthcare costs. And I can tell you definitely they had more information than I had on their own employees. And they began to hire doctors and nurses to begin analyzing the data that they have and tell me as the healthcare provider how they wanted us to manage their patient base. But the information was never, it was never directly around the financials. It was always about the quality and the patient safety aspects. Patient safety is not just have they harmed the patient. It also includes the patient engagement or patient satisfaction in the care that they've been given, their access to prevention within the community, as well as the clinical outcomes that are there. So ACOs play multiple roles. Some of it is directly with the federal government, whether it's a Medicare, Medicaid ACO contract, and others are directly with private sector organizations. So I'll introduce a topic, and I'm sure many of you are familiar, and some of this information was pulled from the Center for Patient Safety. But one of the critical factors in improving patient safety within an organization, particularly an organization that has multiple hospitals. So as I said, I worked for the two largest hospital companies in the United States. So the first one has both of them have over 120 hospitals throughout the United States. And so up to I'd say about 7 years ago, 7 or 8 years ago, if I had a negative patient outcome within my hospital, that was an event that occurred in my hospital that was confidential to my hospital and was never shared other than with the corporate office, but never any lessons learned outside of the four walls of the facility that we had. Even the doctors that were involved were limited information was shared with them just because of legal aspects of things. And so obviously you can tell from this type of environment, opportunities to learn from a safety standpoint are limited and not able to quickly deliver across a greater good, particularly when you start seeing safety issues specifically around, let's say, for example, this supply, this needle was breaking, or this catheter, there was issues with insertion. While we had the obligation to report that to our corporate office and to the manufacturer, there was no obligation for them to share that with any of the other hospitals to say, hey, be on the lookout because this incident happened here, and try to avoid a future event. So a legal structure was introduced called the Patient Safety Organization. This was something that obviously had a lot of federal support, and laws were changed to help support organizations to become a PSO. Again, this is the US structure where, as we know, litigation can be very high. And so depending on the country or the environment that you're in, it may not be necessary to form a legal entity, but within the United States, it's critically important, because what that allows you to do is share incidences that occurred within organizations, and allow the safety or the confidentiality of that sharing to remain within the rights of the overall patient safety organization. And so some of the benefits of the patient safety organization, as I mentioned, healthcare providers can voluntarily report information regarding adverse events, medical errors, near misses, because now they know that all this information is privileged and confidential, and it can't be accessed through a lawsuit or through some type of court system because it's protected under the PSO legislature. To learn from such events to improve healthcare quality and safety. As I said before, what may occur within one department or one organization that may be, let's say, 2,000 employees, while the parent company employs 200,000 to 300,000 employees. The ability to share that information in a safe way with all of the parent company and all the other hospitals within that is a tremendous benefit. One, to educate, but also to potentially avoid harm to patients that may be preventable. And then improved reporting of adverse events leads to a better understanding of near misses, provider and systems, and near events experienced by ACO providers. So this is where a patient safety organization begins to overlap with an ACO. So as I said before, you can be an organization or a hospital that's part of a high reliability and not be necessarily an ACO. But what an ACO begins to introduce is take independent providers. So let's say there's a hospital chain of 100 hospitals, but all of those hospital chains interact with independent providers that have their own business, whether it's physicians or post-acute care facilities. By forming a patient safety organization and an ACO and coming together, you then begin to exponentially be able to share lessons learned under a protected environment. And the amount of data that's shared into one repository that the analytics people can go in and look at begins to exponentially multiply in terms of the lessons learned, or the identification of trends to begin introducing interventions, or confronting poor clinical care to reduce that outcomes. What it also allows an ACO to do is begin to benchmark different providers within the ACOs. So a specific example of this is, as a hospital, I would go meet with all the various post-acute care facilities, whether it was a skilled nursing home, a long-term care facility, LTAC, a variety of different facilities. And we would invite all of them to be part of our ACOs, because we had, at that point in time, we had very limited knowledge on their performance. However, as they joined our ACO, we began to get claims data. They began sharing patient information with us. We began to see more information about our patients, whether it's readmission rates, infection rates within the post-acute care facility. And we could do one of two things. One is we could say, okay, this facility, this post-acute care facility is having issues with readmission rates around heart failure. And we would identify a cardiologist to go around and begin to work with the staff there and round on patients to help improve the care. In some circumstances, the care was so bad and there was negative patient outcomes that we would no longer include that post-acute care facility in our ACO. And that way we knew that we could control the quality and the outcomes, safety outcomes within our ACOs because we could see each other's information. The same thing would go for a primary care physician. Obviously a primary care physician refers their patients to, let's say, orthopedics for a knee surgery. And there may be 10 orthopedic surgeons. And there's historical, informal, yes, I think this is a good doctor, good surgeon, yes, go there, or no, I'm not sure that this doctor doesn't have a good reputation, don't go there. But sometimes those things are driven by personalities or other political conflicts. So what an ACO allows one to do under the guise of a patient safety organization is really take, let's say, 10 orthopedic surgeons' outcomes and create dashboards and benchmarks that can, one, show which doctor does have the best outcome, whether it's infection rates, shortest length of stay, being able to do a surgery on an outpatient basis. But on top of that, also look at the cost of care for each surgeon. One surgeon may use 5 screws to do his surgery versus the other surgeon may use 10 screws. So there's a lot of level of detail that allows for benchmarking between provider to provider. I say all this because, as we know for ACOs, the key to any ACO is that the primary care provider is the gatekeeper and really the one in charge of the patient's care. And so the more we can provide the primary care physician with safety information around other doctors, around hospitals, around post-acute care facilities, the better choices they will make for their patients. Even when it comes to hospital settings, when you are able to clearly show to a primary care doctor, if you admit your patients to this hospital, this is the anticipated outcome, or these are the quality metrics or the safety metrics attached to this, versus if you admit your patient to this hospital, these are the quality metrics or these are the safety metrics. So the amount of information becomes much more transparent, much more accessible in a clean format. And the ACO is an independent body that has the patient outcome in the best interest. Because obviously that improving patient outcome will drive the overall financial performance of the ACO. So becoming a PSO is key to becoming a successful ACO. We mentioned this a little bit, but as physician and hospital and healthcare professional and entities come together to form ACOs, PSO participation provides a protective pathway to for a better understanding of contributors to risk opportunities for improvement and reduction in patient harm. So again, this is a matter of the more information we can share as an ACO about patient safety issues that are occurring, looking for trends, looking for possible improvement area. Obviously, that's going to have a downstream improvement on the overall care of the patient and the overall care of the community. I will say the other thing that ACOs have changed or accelerated that is having a direct impact on patient safety is, as things are in Saudi today, and inshallah shifting in a different direction, but has also been the case in America, where historically healthcare has been hospital focused. And so when you talk about patient safety or you talk about quality outcomes, you're lucky if you have a dashboard of, let's say, 50 KPIs. You're lucky if 2 or 3 of them are outpatient related. For the most part, everything is focused on hospital performance. However, in an ACO model, Success in an ACO is keeping patients out of the hospital as appropriate, which means delivering more care in outpatient settings, whether it's the primary care setting or outpatient surgery, um, or post-acute care type facilities. So the hospital-centric approach to patient safety is unbalanced, and I, I would say under an ACO model is obsolete, because patient safety is directly related to quality improvement. Understanding the drivers of near misses and patient safety events across all segments of the healthcare enterprise, from the home to the provider practice through long-term care. So this is just an example of how the care has shifted. Contributing factors identified in an analysis of nearly 50,000 malpractice claims suggest that seemingly trivial system problems in primary care, such as problems with records and communication with providers, can lead to poor health outcomes. So what does this mean? So, historically, we measure medication errors in hospitals or near misses on medication error in hospitals. But we never really take the next step of saying, okay, the patient came to the ER, I wrote this prescription for the patient to be discharged, or the patient was an inpatient in the hospital, I wrote this prescription for the discharge. Did that communication go back to the primary care physician? Because when the patient shows up in the primary care office, one, will they know what medication they are on? And if they don't, will they prescribe something that may create further complications or a duplication? And so what's identified is clearly there's a breakdown from the hospital in many factors to the outpatient setting to actually communicate what's been done, what was the plan of discharge, having a warm handoff from discharge to the primary care office is critical. So you can see that there's just, if you think about your day, whether you're a physician, a nurse, or an administrative person, and think about how many people you depend on. And these are people that you see day in and day out. Now think about it from a stance of, I'm a primary care physician 60 kilometers away from the hospital. I probably don't even know 99.9% of the people that are taking care of this patient while they're in the hospital. What are the chances of a good communication or good handoff happening? That's why we need to have strong ACOs, because the technology and the socialization of providers begins creating this environment of improving communication, improving sharing of valued and accurate information. And then you can obviously see the downstream impact to improving overall safety. Family medicine and family physicians report a spectrum of medical errors that differ than those reported in the hospital care, with most errors arising from system issues, such as mishandling of administration or communication. As I mentioned, ACOs are changing the geography focus of patient safety to more of an ambulatory outpatient setting. We mentioned that most metrics so far are focused really on the hospital setting, yet the majority of the healthcare visits occur in primary care or ambulatory care settings. Of those ambulatory care visits related to injury, approximately 14% were the result of adverse effect of medical or surgical care or medications. Again, bad communication or poor communication between different care handlers. The outpatient setting is potentially a high-risk environment due to the complexity of care provided and dysfunctional interfaces between inpatient and outpatient. We talk about the chronic care patient being the one that's the high driver of cost and the one that really needs focus. But how good is our communication between, when we say a chronic care patient, between the hospitals and the primary care provider to really actively manage those patients? What have we done to implement tools to help that communication? So, for example, we have a role. We call them care coordinators, but the definition of a care coordinator is very different. Or there's patient navigator that can substitute for that as well. But one of the new areas is in the high volume emergency rooms, putting patient navigators there. And the only reason for the patient navigator is when an emergency room doctor says, okay, this patient is ready for discharge, however, they need to follow up with their primary care physician. That nurse's job is first and foremost to schedule the visit with the primary care physician in their office before the patient leaves and within 72 hours of the patient discharge. Obviously, some of this is driven by the ACO that has contracts with managed care companies that have quality requirements such as this. But it's also, we know, good patient care to have the follow-up visit with their primary care to avoid readmissions. In some circumstances where that's not possible, because of the lack of primary care doctors and the lack of access to primary care, what many hospitals have done is taken their internal medicine or their hospitalist groups and created post-discharge clinics. That the only thing they do is follow up with them within the 72 hours to ensure that everything at home is going fine and they have what they need. Again, these are all driven through the ACO because they are able to identify these patients. They're able to assign a patient coordinator to them, who's also reviewing medication, reviewing post-discharge instructions to ensure patients are achieving what they need to, what they are prescribed for. Providers entering into ACO arrangements will need to shift their thinking from a single purpose to an integrated approach. Obviously, we've all been working for a long time in healthcare, and you get kind of in your routine and you focus on the issue that the patient's facing or the system that's in front of you right then and there. But really, from an ACO perspective, you had to take a step back and think about how do all these pieces and parts fit in with one another, and what is my role in this bigger ecosystem now to ensure that truly the patient is at the center of the care and that I'm providing all the information that I can to the primary care physician to help them manage that patient's care as much as possible. Likewise, evaluation of type of errors occurring in each segment of the ACO. So as we said, there will be different issues in an inpatient standpoint than in an outpatient standpoint. And we really need to have focused review of each segment within an ACO to ensure that we're addressing any patient safety concerns. Efficient, cost-effective care delivery requires access to patient information, decision support, and timely access to benchmarking data. As we mentioned, clearly this is one of the factors of forming an ACO is to improve your overall financial performance from a cost effectiveness standpoint. But the only way to do this is to have good patient information that you're able to make informed decisions about. This can be joined by many different aspects. Some of it is through the providers. Some of it's through not-for-profit organizations that are government entities. And some of it in the United States, a lot of it is actually through the managed care company because they have all the claims data. You have to remember, as an ACO within the United States, you only know if a patient has come within your network as an ACO. It is possible for patients to go to, let's say, the hospital down the street. That's one of your competitors. That's not part of the ACO. The only way you'll know this is through the managed care company that will let you know that you have a patient that has left your network, and then you have to actively work on that. It's critical for that feed of information because that may be a good hospital, but it may be a bad hospital with poor quality and poor patient outcomes. And you will be held responsible for the costs or the outcome of that patient, regardless of whether they're in one of your primary outpatient clinics or hospitals. So managing the population very tightly is critically important. Similarly, the PSO provides data collection and analytic resources that help collaborate with the ACO as well. By combining efforts, providers from all segments of the clinically integrated environment, by establishing a culture that encourages reporting of adverse events in collaboration to identify solution, you would expect the following outcomes. There's an understanding of the type of errors that occur in different parts of the health system, that you identify if and how errors that occur in one segment of the clinically integrated system can affect another part of the system. You understand how activities in one segment of the clinically integrated system can serve to prevent, mitigate, and exacerbate errors in other parts of the system. Potentially reduce the number of errors and improve quality throughout the ACO, and then finally create opportunities to share in saving results from decreased expenditures. I'll tell you, one of the signs of success from having an ACO that collaborates, all the providers within an ACO that collaborate with one another, and having a strong patient safety organization that's sharing information, that encourages all sectors within the ACO to be high reliability. And again, this may just be a US indicator, but is malpractice claims. An organization that I was at, we averaged every year anywhere between, I'd say on average, 30 malpractice claims throughout the year, whether that was for an incident that happened in the hospital, one of our employed physicians, a physician that was part of the ACO. We spent 3 years really focusing in on high reliability efforts, making sure that safety was transparent, that you could have open conversations, that no one felt like if they reported something, they would be targeted, and everyone felt like there was a just system to hold whether the process, the culture, or the people accountable. And I remember distinctly our first year, the only goal, and we actually tied this goal to individual compensation, was to get our serious safety rate, so the rate of people reporting, the highest it's ever been, because we wanted to make sure that we had a transparent environment, that people felt very comfortable sharing information that then we could share across larger groups. So we were successful at doing that. And then, alhamdulillah, over a 3 to 4 year period, we were able to reduce that serious safety event rate by more than 90%. And some could say, okay, well, maybe people weren't reporting as much as they originally were. But that malpractice, where we were averaging around 30 malpractices a year, we actually got a call from our legal team, outside legal team, and saying, what's going on in your organization? And we said, why? And they said, we're losing a ton of money. And we said, what are you talking about? You're losing a ton of money. They said, in this past year, you have only had 3 malpractices. So going from 30 to 3, because we focused on making sure that our environment was safe, and that our providers felt comfortable having open discussions, simply as that. Obviously, if we identified an issue, we had to do interventions. We had daily safety huddles to ensure that things were taken care of in a timely manner. But that was an indication to me that, one, yes, we're improving safety. But obviously, what's a downstream effect of that is for the ACO. Because if your malpractice claims are reducing, that means less money you're paying out in lawsuits, and therefore reducing your overall cost of care. So they're all very tightly related to one another. And the most important thing is the integration between the providers within the ACOs. So finally, a PSO, a patient safety organization's overall objective is to improve patient safety and the quality of healthcare service delivery is well aligned with the ACO, which is charged to improve health outcomes, costs, and quality. And with that, Dr. Hatem, I think that's my final slide.
Yeah, thank you so much, Mr. Sharif, for this very interesting and comprehensive presentation. The floor is now for any question, any comments, either by chat or you can unmute yourself. Yes, please. Yes. Welcome.
Assalamu alaikum, Mr. Hatem.
Marhab. Yes, Adnan, welcome.
Okay, so thank you so much, Dr. Hatem and Dr. Sharif for the wonderful presentation. And we touched base in a lot of points actually. And I think the time is very limited to have a discussion around multiple topics that Dr. Sharif pinpointed, and it's a wonderful discussion around. So my question is only one area, which is the performance management. Regarding we touch base in the cost perspective, we touch base in the different scenarios. So how we make sure when in the journey of the ACO, from the provider perspective, the performance management will ensure the right management and tracking of all the elements that put forward for the ACO. So is it specific? I'm sorry, it's a bit noisy here. Is it any specific methodology being used in the US, in the different ACO model in the US that will help us in the KSA to determine that specific performance management will enable us to track the progression of the ACO in the right track? And this is basically the ultimate way of measuring how things being measured and performance is going forward all the way to graduate to the ACO. Thank you so much.
No problem. So two things I'll say is when you talk about measurements relative to the US and specifically to ACOs, it's interesting because it's a negotiation. In some ways it's a negotiation, with some it's a negotiation, some it's not. So for example, if you do a Medicare ACO, they tell you these are your targets, right? You have to focus on hospital-acquired conditions. You have to focus on patient satisfaction, readmission rates, whatever the case may be. And what they do is they have their performance of the other ACOs, and depending on how they benchmark you against the other ACOs, and depending how you perform is how you'll get paid. So that's with the federal government, and it's very a one-way conversation. Now, when you talk about private insurances, so large insurance plans, Humana, Cigna, Blue Cross, so various large plans that have many, many lives that you're accountable for. That's a negotiation. So every contract looks different. And this is where the ACO plays a critical role, because as a hospital or as a primary care provider, I'm focused on what's inside the four walls of my area. The ACO is the one that has to understand what the hospital is doing, what's the primary care doing, what can we actually perform well on, and negotiate with the managed care company to try to fit those in. Sometimes that's a successful negotiation, sometimes it's not. In the cases that it's not, and the managed care company puts specific quality or safety goals, KPIs that you have to achieve, then it becomes the function of the ACO to do mass and one-on-one education with each of the key stakeholders so they clearly understand what's going on. Obviously, the model in the US is a little bit more, I'll say, engaging for the provider because their pay is tied to it. So for example, a physician in the US many years ago was 100% just, I got a salary. Then it moved to 100% or near 100% productivity. How many patients you see, you get paid. Now it's shifting to, in some cases now, greater on the ACO quality patient safety outcomes than your productivity. Some places it's still 70-30 productivity. So the outcomes are all depending on the contracts that are negotiated. What I'll say for us here within the areas that with what's in our control here is there's clear indicators under becoming a high reliability organization. And I don't know, Dr. Hatem, if you have had a presentation on this, but there's very specific indicators that need to be achieved, whether it's process or outcomes that measure whether you're achieving your goal of becoming a high reliability organization. I can tell you the hardest, as I've seen, as I've spent my time here over the past year, and one of the biggest hurdles that we'll face as becoming a high reliability organization is our custom is, if there's an error, the first question we ask is who did what, right? Which is the opposite of what we should be doing. Chances are 90% of the time, there was a system or a process issue, or there was a culture issue. Yes, the person may have done the wrong thing, but everyone in the department's doing the wrong thing, right? So until we fix the ability to have a transparent, open conversation around these safety events, we'll struggle. So I would say the biggest thing is focusing on safety huddles and focusing on having a just environment are the two most critical things in becoming a high reliability organization.
Thank you so much. Let me welcome and give opportunity to Dr. Khalid Al-Gemezi, VP South and North Region in Health Holding Company. He is also CEO of King Faisal Specialist Hospital for the South. Welcome, Dr. Khalid.
Assalamu alaikum. Thank you, Dr. Hatem. And thank you, Sharif, for this very informative presentation. It seemed music to my ear when we talk about the patient safety around within our journey to become a accountable care organization. Given the dynamics that occurred in the United States with different modeling and change over the time, and also having different drivers for the healthcare delivery from provider perspective, practitioners or clinicians perspective, and patient perspective, and their perspectives. How do you envision this one can be well organized in our system, where we are changing all the component of the ecosystem, the regulator, the payer, and the provider? And how can we keep the patient safety agenda and the clinical governance in general, the top priority within the boards, within the executive team daily activity, and then the regular meeting of the boards?
Yes. Thank you for the question and the input. I think we're at a point right now, particularly with the transformation, that is a critical component. And the part of it is the CNHI negotiation for a potential contract, because I think that we can see it with ADAT or other national indicators that the focus is whatever's being measured, right? And so if it's not being measured or it's not being prioritized, the chances are it's not going to happen. And I think that's where, and I've seen, some of the conversations around FOB and the cluster, that I do believe there is a heavy focus on making sure that quality and patient safety are at the forefront. And I'll say one of the major differences between the US and Saudi is the majority of leadership here is clinical, right? Versus in the US, most hospitals are run by business people. So I think the clinical component will always be at the forefront, but the specific areas of patient safety and specific quality indicators won't become the main priority until it becomes a national priority or a contract priority. As soon as the finances get switched and it's no longer, a block budget based off expenses and the budget based off outcomes, you'll see behaviors dramatically change and decisions dramatically change because of that. As far as the engagement of the board and other leadership, what I think is critical is structure. So, one thing that we are trying to do, and I think that other places, at least in the US, you have to have the board agenda developed a year in advance. Obviously, there's things that are going to come up, but from a quality and patient safety standpoint, every month it must be on the agenda, but it can't be, okay, let's talk about this month and then randomly pick another subject another month. You need to, at the beginning of the year, have a concrete plan on what's critically important to the organization and have it on the agenda. The other thing that was very helpful, and you see it a lot in not-for-profit hospitals, similar in the US, similar to the ones here, is we have the board, we have the subcommittee of the audit committee, which are very active. We have benefits and comp committee, but there's no subcommittee that's focused on quality. And so I think the formation of a subcommittee with board members actively participating with quality will help improve the engagement. So to me, it's our job as the leadership team to deliver the transparent message not just show the good numbers, but also show the bad numbers around quality and patient safety to our board, and really educate them. But we have to do it in a structured manner. And there's lots of education materials on how to engage your board on with quality, and what are the topics they should be covering.
Thank you so much. Any question? Any comment? Let me welcome also Dr. Mahmoud Abdurrahman. He is the consultant of preventive medicine. Welcome, Dr. Mahmoud, and also Dr. Ibrahim bin Hussein. Welcome. And I would like to welcome you all.
Assalamu alaikum wa rahmatullahi wa barakatuh.
Marhaba.
Walaikum assalam.
Thank you, everybody. Thank you, organizing team. Thank you, Mr. Sharif. I would like to thank you about your presentation, and I want to clarify and ask about some point. In relation to was the last point what you mentioned about the board of quality in each organization, that's already had been established in our institution according to the mandatory requirement of SIBAHI and Patient Safety Center. There is supposed to be mandatory quality and patient safety committee, which is led by the higher leadership in the institution. In addition to there is supposed to be a patient safety officer and risk manager in each institution. That's a movement toward the improvement, as we said, in the quality. The second thing, which I agreed with you, how we can reach to the outpatient, or let us to call it continuity of care, which can help us in maintaining the patient safety even outside the institution. The third thing in relation to culture of patient safety, we know now the Saudi Med, according to the requirement of medical school curriculum and healthcare institutions, it has to be part from their curriculum, some part related to patient safety from the earlier year of education and healthcare specialties, which can drive us toward patient safety culture, which is embedded from the early stages of education and healthcare service, that we are looking for to embed the patient safety culture. Always I told my student, you have to be a safe practitioner for yourself, for your patient, for your organization, and for your community. If we embed that in during the early stages of education and inside the curriculum with the good practical amount, I didn't say about the theoretical. We have to engage them in some practical activity which transform their knowledge into skills which to be maintained in their life of life journey of healthcare provision. I would like to hear from you how we can reach the community and outside the patient from accountable care organization. Thank you.
Thank you for the comments. I think on an outpatient basis, from focusing on how do we begin to enhance or identify the patient safety concerns. Some of it is, and some of this is very new also in the US, is really putting the resources. We have risk managers in the hospitals, but how many of us really have risk managers in our outpatient, dedicated risk managers in our outpatient setting that's working with the staff to identify potential patient safety issues? So I think we need to look at that setting. And when I say outpatient, I truly mean non-inpatient. So if we have ambulatory care, or if we have orthopedic specialty hospitals, even though they're sitting on the hospital campus, that's an outpatient setting, right? So we need to make sure that we have the right resources that are dedicated, looking for opportunities for improvement with the staff there, because, as we said, there are going to be very different challenges. that what someone faces in an office versus what they'll face in the hospital. You know, a simple example is we have very good processes to identify fall risks when patient comes into the hospital. But I've had incidences, a couple of incidences where we have a patient in our outpatient setting in a primary care office. We go to weigh them. They were a fall risk in the hospital 3 days earlier, but we go to weigh them and we leave them on the scale by themselves and they fall and injure themselves. So there's opportunities to improve the communication and look at those risk areas to say what are interventions that we need from that standpoint. You know, as far as engaging the community, I think it's the most difficult part, particularly when healthcare is free to a certain segment. So, for example, in the United States, Medicaid, most patients either have no deductible or very low deductible. And there's no penalty on them whether they show up into the emergency room or they show up into the primary care. And so those are the most difficult groups of patient populations to really get to change behavior, because there's no financial penalty or financial incentive for them to do that. So the only way that I've ever, and I can tell you it's still a struggle, is somehow you have to improve the experience that they have on the outpatient setting so that they feel comfortable going to their primary care physician. The other component from a engagement is, and this is the most difficult thing that I've tried to get a primary care doctor to do, is wellness visits. So in the United States, Medicare will actually pay a doctor twice as much to do a wellness visit, of which 90% of that wellness visit can be done by a nurse, and the doctor just needs to go in for the last 5 to 10 minutes and make sure everything's okay. It's still very, very difficult to get a primary care doctor to do that visit because they're so focused on treating the chronic issues that to say, hey, let's talk about wellness visits becomes a foreign subject. But to really understand our population, before they're ever sick, it's getting them into the physician office to do the wellness visit, because obviously that leads to the appropriate screening and early catching of diseases that may be preventable or at least better managed. As far as citizen engagement, it's a struggle. I think everywhere. I don't have an answer for that one, honestly. But I can tell you where we're focused here is really how do we create a strong platform to accomplish the wellness visits so that we can better understand the community that we're serving.
Thank you. Any question, please? Yes, تفضل أستاذ ماهر. Welcome.
Yes, Assalamu alaikum wa rahmatullah. This is Maher al-Anisi, performance manager at the North region. Actually, thank you for your kind organizing this event, and thank you for the presentation itself. Actually, my question is around the system of alignment that we just presented in based on the network governance and the quality deliverables that we are focusing right now to build the governance and the framework itself. So I'm asking about the framework or the performance framework. Is there any tips for building this framework that's including a lot of divisions right now in the healthcare, Saudi healthcare? And is there any, let's say, a model that's going on in US or any Europe countries about the system of alignment to perform the implementation of the transformation of the major project that's going on in the industry? So would you just give a clarification about this topic and how we are going, inshallah, to build it within a good tips or guidelines or a model that's implemented before? Thank you.
Thank you. I think this one's going to be, it varies country by country. Again, I'm sure that whether the British or the Europeans or the Australians, they do it probably different than the US. Alignment in the US is financial alignment. That's what it boils down to, and it's the quickest way to transition something. So what I say that is, so for example, under old fee for service, if I'm a doctor, I see my patient, I bill for their service, I get paid. The hospital sees the patient, gets billed for the service, and they get paid. So everyone was doing their own thing. Now under an ACO model where that you have capitated rates, the ACO actually gets a bundle payment. And based off performance is how they distribute the money. So I'm incentivized to provide good quality of care and good patient service, because if I don't, my income will be impacted. If I do, then I'll probably make more money than I was before. Obviously, that's a completely different model than what we have here in the kingdom. I do think that here, there is a greater focus on wanting to do the right thing for the patient, because these are all of our friends and families, right? This is the community, this is the country we live in. So I think there's a greater ability to for identifying different motivations. But I can't stress enough that that definition or that identification of what is the motivating factor is going to come down, in my opinion, is going to come down to the cluster's arrangement with FAB, because that is the contract and that is the terms and that's the, let's say, the playing field that will define how we interact as a collective healthcare ecosystem, right? Because we may need help from the private sectors. Each cluster may need help from one another, right? And we all have to be incentivized in a common way to achieve a common goal, which is improving the patient outcome. So I can't give you a direct answer on how it would work here, because I think that is a journey that's honestly just beginning and will take a while to flourish out. But what no one will ever argue about is keeping patients safe, right? I always tell people, listen, whatever mistake we make, we can fix. Other than harming a patient, you can't change that. And so if we can just focus on improving patient safety, which we know there's evidence-based tools to do that, then I think we have to act from a common good. If in that conversation you can't get a person to agree to that, then you have to question the person you're having the conversation with and if their motivations are correct. But for now, I think if we just focus on keeping our patients healthy and safe and not making them worse than when they came into the office or to the hospital, no one should be able to argue with that.
Thank you so much. Any further question before we go to, we have also certificate of appreciation. We requested you, Mr. Sharif, to appreciate some of the leader of the group, maybe just a while, but I would like, any questions so far? I have a question, if you allow me, Mr. Sharif, is that you know that there is a great effort here in the kingdom by the health holding company to establish a culture of accountable care organization. And one of the excellent product is the Accountable Care Organization Manual. And definitely this manual defines the scope, the governance, capabilities, and different capabilities that lead the cluster to move towards ACO. So my question relates, maybe do we need, for example, like capacity building program? This is definitely a nice presentation you deliver is one of them, but maybe it is not enough to master and even to digest the basic concept. Do you think we need to have a training program in ACO at different level, targeting corporate level, hospital level, and PHC level?
Yeah, I think from an ACO perspective, if we're talking specifically ACO and everything that's encompassed within an ACO, I definitely think the more education, the better. I think the thing that has to be defined more clearly, as I mentioned, you know, from my past experience in the US, there are many different types of ACO, right? There's physician-only ACOs, there's network ACOs, there's ACOs that are full risk, partial risk, all different types, right? So I think we can talk in general terms, but we really need to clearly define what type of ACO we're going to be as an individual cluster, right? Because every cluster, I know it probably won't be, and the preference is to have a single platform, but there is the potential that each cluster could look very different from an ACO standpoint, right? So I think the first step is, what are we going to be defined as an ACO? You know, it's very easy to form, taking, let's say, for example, in E1, we have 22 hospitals, we have 130, over 130 primary care offices. Taking all that and forming an ACO is a very, very difficult, long journey, which we're on. But if I just take my 130 primary care offices and start with an ACO there, that becomes much more manageable and can be done very quickly. So I think we have to really sit down and say, what components do we want to start with, and where do we want to end up to be? And that's a leadership conversation that needs to happen to define that. But yes, to your question, I think the more education on what an ACO is, what a high reliability organization is, what value-based care means, and really beginning to define these things. You know, service lines. What I've learned in my short time here is we define service lines very differently here than other places do. Health coaches are defined very differently. Care coordinators are defined. We really need to bring concrete definitions with job descriptions and roles and scopes so that everyone understands where we're headed.
Thank you so much. I think now is the program of appreciation. Dr. Samah Najib prepared some virtual certificates for you, and definitely would like from you to appreciate our weekly instructor. As I told you, we have a weekly instructor that raise some issues related to the quality. Dr. Samah, the floor is yours now. Dr. Samah Najib, yes. Yes, thank you so much. This is just maybe a virtual certificate for you. This is actually
COVID certificate, huh?
We will send it to you.
Yeah, thank you. And I appreciate the opportunity, and inshallah, it was helpful.
Yeah, we would like also from you to give our leader the certificate. We have Dr. Atifa, yes, can you share the certificate of Dr. Atifa, who leads the discussion in a patient safety? And also we have Amal. Amal, are you with us now? All are powerful ladies. This is a week of mother and week of woman. Hunaida, yes. Yes, Dr. Atifa Gismallah Muhammad. She leads the discussion from week 7 to 13. Thank you. And also Amal. Amal, please. And Hunaida, and also for you, Dr. Samah. Yes, maybe there is a slow in the network and sharing, but we are glad, yani. Yes, thank you so much. Dr. Amal, are you with us? You would like to say something? Dr. Amal? Yes, thank you so much. Dr. Hunaida? Dr. Hunaida? This certificate actually just for those who are joining us, this group is called Sudanese CBHQ Patient Safety group, although it names Sudanese, but include all the nation, with the purpose of increasing the knowledge and skills in patient safety. We have a daily discussion by WhatsApp. We have a weekly presentation, and this 16 presentation, Dr. Hunaida Saleh, thank you. And last but not least, for our group active member, Dr. Samah. She is working on the educational plan for the whole year, including the different topic of patient safety. Dr. Samah Najib, thank you for your effort again. Thank you, Dr. Samah Muhammad Najib. And by this, we conclude our session today. Thank you so much again. And next week also, let me announce, we will have a distinguished professor in Saudi Arabia, Professor Zuhair Subai. He's a well-known, he's the professor of community medicine and family medicine, and he will deliver a presentation next Saturday about the role of healthcare provider in the health of the community. And this is definitely one of the areas. Thank you so much, and see you next week. Thank you so much, Mr. Sharif, again, and thank you for you all for your attendance today. Assalamu alaikum wa rahmatullahi wa barakatuh. Thank you so much.